Before we start our CME today, I would like to remind the participant to turn off your microphone during the talk and don't forget to register for for attendance. For medical practitioner, kindly fill in the Google form for CPD point. The Google form link will be given in the chat later. Without further ado, I would like to invite Assistant Prof. Dr. Khairul Anwar Ibrahim from Department of Ophthalmology, Sultan Ahmad Shah Medical Center, to give his talk with title Red Eyes, More Than Meets the Eyes. Tafadhal, Doctor.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and very good morning to all. Sabah al-khair, sabah al-nur, sabah al-ward. Okay, so today I've been given task to actually discuss a topic with entitled Red Eye, More Than Meets the Eye. So let me just share the slide first. Okay. So can you see my slide now? Okay, so Bismillahirrahmanirrahim. My name is Dr. Khairul Anwar bin Ibrahim from Department of Ophthalmology. For today's CME, we will review a common complaint in primary healthcare and general practitioner or even in an emergency department, which is the red eye. So basically, red eye is due to engorgement of the conjunctival blood vessels. It can be due to multiple causes. Common causes such as conjunctivitis, be it viral, bacterial, fungal, or even parasites. And then it could be to scleritis, which is the inflammation of the sclera. And then we do have the episcleritis, which is the upper layer of the sclera underneath the conjunctiva. And then it could be due to trauma, dry eye, or it could be even secondary to other problem, sometimes due to the systemic disease. Okay, so the table content of my presentation for today. First, we'll see a case presentation, and then we'll have a review of the anatomy of the eye, and then we will review regarding the red eye, and then have some take-home messages, and then the references. So let's begin. So for case presentation, so this is a Madam M. She's a 45 years old Malay lady. She's healthy with no underlying medical illness, no known drug or food allergies, and she also denied any previous ocular procedure or other medical or surgical procedures presenting illness. She initially presented to our clinic in May 2021 with a complaint of left eye sudden onset of redness. So this is the first episode. She never had any same previous episode prior to this. And then she said it is associated with pain, in which she described as throbbing in nature, but there's no radiation elsewhere. It is partially relieved with painkiller, but otherwise it doesn't really affect her sleep. Yeah, and then she denied no history of trauma to the eye, no eye discharge prior to this, no headache, no nausea or vomiting, and then no other family members with the same problem. As for the associated symptoms, she further described the problem associated with symptoms of dry mouth and dry skin. But she denied any joint pain, on no skin, facial skin redness, and she denied of promiscuity. Okay, and then as for the physical examination, visual acuity test on both eye yield normal result with a 6.6 on both eye on Snellen chart at 6 meters. And then relative afferent pupillary defect or RAPD was absent on both eye. So it means that it is not affecting the optic nerve. And then the intraocular pressure on the right eye is 18 millimeter mercury, and then 17 millimeter mercury on the left eye, which is in the normal IOP is ranging from 11 to 21 millimeter mercury. Okay, as for the anterior segment examination of the right eye was significant. insignificant, while the left eye only abnormality detected. The only abnormality detected was the injected conjunctiva nasally on the nasal side, but otherwise no eye discharge. Cornea is clear, and then the anterior chamber is quiet with no activity. Pupils and lens was relatively normal. And the posterior segment examination of both eye was unremarkable. Everything was normal. So this is the the initial pictures of the patient. So we can see, noted that the anterior segment photo is there's injection of the conjunctiva on the nasal side. But otherwise the cornea is clear. You can see the pupil is round. The eyelid was normal with no eye discharge seen. There is no nodular or any other discoloration of the conjunctiva. Okay, so at this point of time, the diagnosis was a left eye episcleritis. So basically, this diagnosis was made after confirmation test by phenylephrine test, in which the left eye was instilled with phenylephrine, which is midframe. So it is a direct-acting sympathomimetic amine chemically related to adrenaline and ephedrine. With a potent vasoconstrictor property. So phenylephrine is a post-synaptic alpha adrenergic receptor agonist that causes the vasoconstriction. So in this test, the vessel blanched after instillation, and the diagnosis of episcleritis was made. So patient was started on Nevanid, which is non-steroidal anti-inflammatory drugs, and then also artificial tears. And then on subsequent follow-up, we noted that the redness is not improving. And then there is associated corneal opacity adjacent to the injected conjunctiva. And then she's been complaining of grittiness and foreign body sensation over the nasal side of the left eye. But otherwise, her visual acuity was not affected. Anterior and posterior chamber examination was unremarkable. And this is the subsequent photo. And then we can see there's increased vascularization of the conjunctiva, which is more engorged now. And there was a corneal opacity adjacent to the injected conjunctiva, which is in the limbal area over here. Over here. You can see over here. And then, but otherwise, no eye discharge seen. Upper and lower lids were normal. And then there's no other discoloration of the conjunctiva. Okay, and then anterior segment examination shown there's a crater-like lesion over the left nasal limbal area. But otherwise, anterior chamber looks deep with no obvious hypopion, which is accumulation of the white blood cell in the anterior chamber. And then there's no other lesion elsewhere on the same cornea. Okay, and then the parallel E-pipe examination, which is when we slit the slit lamp light. Okay, we can see that the crater is more obvious over here. And then further, with the higher magnification and optical section, we can see that there is a corneal thinning in that area, in which the cornea has lost about 50% of the corneal thickness. So at this point of time, diagnosis of left eye peripheral ulcerative keratitis was made on top of the episcleritis. The pathology possibly due to the inflammation that accumulate over the conjunctiva due to the episcleritis, which has been affecting the cornea and causing the thinning. And then the patient was started on topical Pred Forte, which is topical prednisolone, 1 drops 4 times per day. And at the same time, systemic steroid was started in view of the crisis and then possible systemic involvement. Okay, she was then investigated for possible infective disease prior to start of the medication. And then a review of the previously taken investigation shown that rheumatoid factor was negative, which is the common cause of recurrent scleritis and episcleritis, but otherwise patient doesn't have any joint pain or stiffness. And then anti-nuclear antibody was negative, complement factors were within normal range. And then patient was then referred to rheumatology for further examination and workup to rule out systemic problems since her condition was not improving and with additional dry mouth and dry skin complaint. Okay. And then on subsequent follow-up, patient noted that the lesion is improving and her symptoms of dry mouth and dry skin to be improving. She's currently happy with her current condition. She's currently under rheumatology follow-up together with ophthalmology for on our side, basically for symptomatic control. And then the steroid has been stopped in view of the peripheral ulcerative colitis is improving. But otherwise, the rheumatology side, they started pilocarpine was added. And then this is basically for control of the dry mouth, in which it will stimulate the parasympathetic nervous system. So this is the current, this is the latest pictures that we have of Madam M. So basically, we can see that the conjunctiva is still injected over the nasal side, but it is blanched with midframe. So still the episcleritis diagnosis still being made, but there's no more left eye nasal corneal limbal lesion. You can see it is clear over here, and then the cornea looks clear. But patient might need prolonged anti-inflammatory medication, which is systemic anti-inflammatory medication, such as systemic steroids, to control her condition. But we need to work together with our rheumatology counterpart for long-term treatment plan. Okay. So then we have a look at the review anatomy of the eye. So basically, this is the the external anatomy of the eye. So first of all, we have the eyelashes, okay, and then over here, this is the cornea, and then this is conjunctiva. So basically, we say this is a temporal conjunctiva, and then we have a caruncle. Okay, so conjunctiva is the area where the red eye got its features. So it has a blood vessels within it. But underneath there is tenon capsules, and behind the tenon capsules there is sclera. So inflammation of the sclera or episclera will cause injection of the area or the whole conjunctiva depending on the cause. Okay, and then this is the cross section of the globe. From the anterior is the cornea, which is normally clear. And then we have the anterior chamber, which is separated from the posterior chamber by the iris, and also the pupil in the center connecting the two chambers. It also, the pupil also act as stopper of excess light coming into the eye. And then we have the clear lens, which hold in position by the suspensory ligament to the ciliary body, or zonules, which will control the dielectric power of the lens to see near and far. And then behind the lens, we have vitreous chamber over here. And peripheral to it is the retina, which is as converted to convert the light energy to electrical energy to be sent to brain as impulses through the optic nerve to process and recognize. And then we have the fovea centralis, which is the most important part of the retina for seeing. Okay, so that basically the basic anatomy of the eye. And then we have to look at the red eye. So just now, the patient currently being investigated for Sjogren's syndrome. So basically, Sjogren is a chronic autoimmune disease characterized by dry mouth and dry eyes. The disease can occur by itself, which is the primary Sjogren's syndrome, or it could be associated with another rheumatic disease, such as lupus, rheumatoid arthritis, or scleroderma. And then it's usually called secondary Sjogren's syndrome. Okay, so basically this is the possible diagnosis of the underlying cause of red eye. So we can first patient presented with red eye and then with pain, and then we further divided it to whether this is a mild or no pain, or mild or blurred vision, which is could be to hyperemia, which is further can be either focal, which is could be episcleritis, or diffuse. And then within diffuse, whether any discharge or no discharge. If there's no discharge, this could be just subconjunctival hemorrhage. But with discharge, it could be intermittent discharge, could be because of the dry eyes, or is it because of continuous discharge? And then we further look at the discharge, whether it's watery or serous. And if it's with itching, with mild to none, it could be just viral conjunctivitis, which most of the time will resolve by itself without treatment, or it could be moderate to severe itchiness. This is more likely to be due to allergic conjunctivitis. But with mucopurulent or purulent discharge, it could be either to secondary to chlamydia conjunctivitis, or it could be to other bacterial conjunctivitis. But otherwise, if the pain was moderate to severe pain, and then associated with vision loss and distorted pupil and cornea involvement, we need to think of emergency of ophthalmic condition, okay, such as severe mucopurulent discharge with a hyperacute bacterial conjunctivitis, keratitis, corneal ulcer, acute angle glaucoma, iritis, traumatic eye injury, chemical burn, scleritis, or even vascular rash due to hepatic keratitis. So over here, urgent emergency ophthalmology referral is needed. So basically, this was taken from this paper from Academy Family of Medicine, a physician. And then this is selected differential diagnosis of the red eye. It could be due to conjunctivitis, whether viral, okay, such as or it could be due to herpes zoster ophthalmicus, bacterial, chlamydia, or could be due to allergy, and other causes of red eye such as dry eye, blepharitis, or inflammation of the eyelid. And then it could be corneal abrasion and foreign body into the eye. It could be due to subconjunctival hemorrhage, episcleritis, keratitis, iritis, glaucoma, especially the acute angle closure. And then we do have chemical burn and scleritis. Okay, so just to summarize, basically this is a small part of the possible cause of the red eye. We can further divide it to whether it is infective in nature, which is local or systemic. Okay, it could be because of the conjunctivitis, the bacterial or viral, or could be due to endophthalmitis, or it could be due to keratitis. So basically, keratitis is actually infection to the cornea itself. And then ulcers. Difference between keratitis and corneal ulcers. So basically, keratitis is actually the inflammatory. I mean, it is caused by the inflammation of the infection rather than the infection itself. But while the corneal ulcer, so basically, it is due to the infection. Okay. So other than that, we can divide into inflammatory, such as in episcleritis, scleritis, uveitis, which is the inflammation of the uveal tract, which is consists of the iris, the the choroids, and also the ciliary body. And then sometimes, most of the time, thyroid eye disease is actually top of the list. And then allergy. Others we can such as trauma, dry eye, or acute angle closure attack. So we need to think of life-threatening condition first, only then the sight-threatening. Okay, over here I will show you some pictures of dry eye, of red eye, and then with the possible diagnosis. So this this photo, this is photo taken from internet. So it is showing injected conjunctiva with the follicle in the inferior palpebral conjunctiva. Okay, but otherwise you can see that the eyelashes and then the lid was normal. There's no purulent discharge. Cornea is clear. Pupil is round. So basically, this is likely due to viral or allergy. Okay, while over here, we can see that the conjunctiva is injected, associated with purulent eye discharge with matted lashes. Okay, so this is basically a bacterial conjunctivitis, which we can see there's a purulent discharge and a matted eyelash. And then in this case, we need to prescribe patient topical antibiotics, and definitely we need to review it earlier. And then, okay, So next, this is the typical pictures of endophthalmitis, in which endophthalmitis is a purulent inflammation of the intraocular fluids, vitreous and aqueous. It is usually due to infection. Okay, but sometimes it can due to systemic inflammation. But otherwise, the picture showing post-operative endophthalmitis, and then the causes could be exogenous, such as in this case, the post-operative. So from the normal flora or from the pathogen external of the body. And then, but it could be sometimes due to endogenous, such as in systemic infection. Okay, we can see over here that the conjunctiva is swollen and injected 360, and then with the mucopurulent discharge, and then you can see that the eyelid is swollen, superior and inferior, and then matted eyelashes. And then most of the time the vision is obscured. Okay, basically because of the severe inflammation is happening inside the eye. Okay, and then the next one, this picture is showing a scleritis. So basically this is how scleritis looks like, in which the vessels are deeper and then it is engorged. And then we can see there's some blackish discoloration over here. So this is basically actually due to the thinning of the sclera, and then we can see the choroid underneath it. Okay. In which thinning of the sclera will show the underlying layer, which is the choroid. So delayed management can lead to further thinning of the sclera and then can cause perforation of the globe. Okay, scleritis are almost always associated with systemic autoimmune disease, such as rheumatoid arthritis, lupus, seronegative spondyloarthropathies, and vasculitides such as granulomatosis with polyangiitis, or previously known as Wegener. And then we have polyarthritis nodosa. This is all most frequently seen. So first we need to stabilize the condition, the inflammation, and then we need to screen the patient, and then definitely we need to co-manage with rheumatology and medical for the further treatment, and then for the systemic control of the condition. Patient definitely might need systemic anti-inflammatory. Okay, and then this is another cause of the red eye. So this is subconjunctival hemorrhage, which is also known as hyphospargma. Okay, it is actually occur when there is bleeding into the potential space between the conjunctiva and the sclera. You can see this is all blood, not just engorged blood vessels. So this can occur secondary to any activity resulting in a Valsalva maneuver, such as coughing, sneezing, straining, vomiting, or even after ocular surgery or trauma. And then as a result of certain types of viral conjunctivitis or spontaneously, such as in bleeding tendency, patient with bleeding tendency. Okay. Individuals on anticoagulation, those with systemic vascular disease such as hypertension, diabetic, atherosclerosis, and those with systemic condition causing decreased coagulability are more prone to developing this condition. And then most of the time, it is typically asymptomatic, and it will most of the time resolve spontaneously. Okay. As for the management, it can be divided into local and systemic management. Okay, so for the local management, definitely we need for local management, treatment could be symptomatic, which is to relieve the symptoms temporarily, or it could be a therapeutic type of management, such as antibiotics in infection and anti-inflammatory such as steroids, or it could be diagnostic to differentiate with other conditions, such as in differentiating between scleritis and episcleritis. Okay, and then at the same time, it is also can be such for prophylactic purpose. Okay, and then while systemic, we need to investigate for the possible cause, and then refer as needed. So in cases such as in episcleritis or recurrent episcleritis and recurrent scleritis, definitely we need to look for systemic disease such as autoimmune disease, because definitely the eye could be the presenting symptoms, but ultimately it can affect the other system as well. So it might cost the patient their life. So that's why if the scleritis or episcleritis or the eye redness is not improving after sometimes with the treatment, we need to further investigate for the possible causes. Okay. And then definitely after that, we need help from our colleagues from other department to co-manage the patient. Okay. So what are the take-home messages? So first of all, definitely we need to establish diagnosis. So if unable to establish possible diagnosis, diagnostic tools needed to be used. But the utmost important tools, which is the history, it should yield all the possible diagnosis and can be further confirmed with the examination, just like any other discipline. And then you can start your treatment, but need to review the patient for improvement of the sign and symptoms. If at any point of time there's no improvement or there's a worsening of condition, definitely you need to refer to the respective team. In this case, you can refer to us. And then if possible, try to send the relevant investigation. But we will definitely look for all the possible causes when we review the patient. Okay, and then definitely refer to other department will be beneficial, especially in the patient interest. So either with confirmed diagnosis of certain condition or to rule out possible condition which is more familiar to other respective team. So that's why we need to refer to patient. And then always work together with everyone, and there's no one above another, and we need to respect others. So this would be the references for my presentation today. With that, thank you for listening.
Thank you, Dr. for your interesting talk. Now we open the floor for Q&A session.
Okay, the first question from Ahmad Shamsi. Salam, do we have oftal on call out of hours? Yes, definitely. We are doing active call nowadays. So at any time, if you have problems, definitely you can refer to us. Thank you for your question. So any other question? So I hope everyone able to follow through my presentation. Can we prescribe a CMC to toddlers? So the answer would be yes, but sometimes I think nowadays I'm not really sure whether we are still using the same formulation, but last time they say patient below 2 years old, we cannot prescribe it. But I think now if you are unsure, maybe you can refer to ophthalmology for our opinion. But most of the time we do start, but you need to review the patient, especially after 3 days. If the symptoms is not improving, maybe the pathology or the possible organism is something else which is more susceptible with other topical antibiotics. But for that, you need to refer to ophthalmology for the medication. Okay, thank you, Farid, for the question. And then from Hosni Zainal, from an ophthalmologist point of view, what would be the other features suggestive of Sjögren's syndrome? So basically, for Sjögren's disease, it is big on our part. It is categorized under the dry eye causes. Okay, so under dry eye, can be further divided into whether aqueous deficient or into the evaporative type of dry eye. So in Sjögren's syndrome, basically, it falls under the aqueous deficient, in which the aqueous component of the tears is deficient, hence giving the dry eye symptoms. But I mean, in terms of signs, I think if you are looking with the naked eye without the proper tools, it's a bit hard to say. We can just postulate based on the symptoms of dry eye, and then also other other symptoms, such as in this case dry mouth and also dry skin. So that's why we're suspecting the dry possible Sjögren's disease, because of the non-responsive to the treatment with the local medication. But patient does improve with the systemic steroid. Okay. Okay, for red watery eye, do you suggest CMC as first line or artificial tears, especially at home? Okay, so basically, if you see a red eye cases, so definitely you need to further ask a question, especially on the duration of the onset. And then you need to examine the eye, looking for whether is it just watery, or is it associated with any other purulent discharges. And then another thing is, most of the time, if it's just watery, and then you do have contact with other people with the same problem, whether in your household or your friends, most of the time it is due to the viral. Basically, viral, it is self-limiting, but it do take sometimes, and it is contagious. So you need to isolate yourself and then wash your hand. So whether to start with a CMC or artificial tears, I think most of the time, if we confirm or I mean, our diagnosis most likely to be viral, most of the time we just simply start the artificial tears. But if you do suspect bacterial, you can start CMC. But to start which one first, I think definitely you need to look at the red eye as a whole, rather than just just the red eye. Okay, thank you, Shamsi. And then next question from Farih Najiha. Does floaters need an emergent referrals? When do I need to refer? Okay, definitely. Depends on the onset. If it's sudden onset and then associated with loss of visual field, definitely you need to refer the patient urgently, because we need to rule out possibilities of retinal detachment. But otherwise, if it's the patient has been having the symptoms for quite some times, and then the numbers and also the size of the floaters doesn't increase, you can get early TCA to review. But I think if you are suspecting possibilities of retinal detachment, definitely you can refer as emergency, because because if we get the case earlier, and then with the macula is still intact, definitely we need to post the patient for for the attachment of the retina. Okay, I hope that answer your question, Farih.
We still open the floor for other questions.
Okay, you can maybe ask directly, or you can just type your questions in the chat box. Okay, so basically, just letting you know, we ophthalmology department, we have started our on-call active call since June this year. So basically, we do have medical officers, specialists, and also consultant on call daily. And then you can refer, and then usually based on your presentation, we will decide whether we can see the patient. We need to see the patient immediately, or we can see the next working day. Because most of the time we do need to see the patient with our tools, whether with a slit lamp or the direct ophthalmoscope, and sometimes we need support from other staff, especially for certain examination. So that's why you need to properly assess the patient. If you think that the patient would be benefit from the urgent referral, then you can straight away refer the patient. But if you think, or even if you are unsure, you can just call us for opinion. Okay. Yeah, and then for during the office hour, we do have beside the on-call people, we do have another medical officer doing emergency clinics in our ophthalmology clinic. So you can ask them for opinion. Okay. Yes, thank you very much, Dr. Aidila, our head of department. So ophthalmology, we have eye casualty clinic from 8 to 5, Monday to Friday. So you can refer directly for assessment. Okay.
Okay, Dr. I think there's no question. Okay, thank you again for your interesting talk today. Okay, we gained a lot of knowledge. Okay, I would like to remind the participant to register attendance in the IATN medical practitioner to fill in the Google form through given. We end our CME today with Tasbih Kafarah and Suratul Ams. And again, thank you, Doctor. Okay, we end our CME today. Assalamualaikum.